webinar on our new report, which is called Scarred for Life, the 2020 update. It's a national report on patients' experiences with hidradenitis suppurativa. I'm very excited that you're joining us today at 5:30 on a Friday. Thank you so much. Thank you so much for joining us. Today, Dr. Raed Alhusayen is going to walk us through the report's key findings, which focus on patients' experiences with the healthcare system, how they access treatments to manage the disease, and how the disease impacts their daily lives. We were really encouraged to see that awareness about this disease does continue to grow, but we can see from the data that patients continue to wait a long time to have their disease properly identified and to really open up the possibility of a tailored treatment plan. Dr. Alhusayen is also really involved with the Global HS Registry, which was developed in response to COVID-19. And so we're really delighted that he's going to share with us some information at the end of the presentation about the impacts of COVID-19 on people living with HS as well. So we know after looking at this report, we know that we can do better for people with HS here in Canada. And in order to get us there, we've identified 11 recommendations, and these go to healthcare providers and policymakers in hopes that this will improve awareness about HS. It'll improve the care and management of the disease, and it will ultimately improve the lives of HS patients. So I want to let you know that all participants' microphones are going to be muted during the webinar. And if you have any questions throughout the session, there's a chat box down in the corner of your screen, and we invite you to enter those there. And Dr. Alhusayen will answer them at the end of the presentation. I also want to let you know that this presentation is being recorded so that we can share it with people who weren't able to join us today. So it will live on our website and on our YouTube channel. And thank you, Dr. Alhusayen. Over to you.
Thanks, Rachel, and welcome everybody. Happy HS Awareness Week, and thanks for joining on a Friday afternoon. I'll get on with my presentation, and I'm delighted to share this work that I had the pleasure of working with CSPA over the last few weeks, or actually a few months on this project. We also were involved back in 2017 with the first report. So it's nice to see some of the changes that happened over that period of time. So these are my disclosures. So starting with some information about hidradenitis suppurativa, and we all know now that it's a chronic inflammatory disease. Some people, to me, it's not really. Some people are arguing whether this is an autoimmune or inflammatory condition. As long as we agree that there's inflammation and could be autoimmune in nature, it's not an infectious process. I think we're all in the same page. So within that spectrum, it doesn't really matter that much. It affects up to 4% of Canadians. We did a survey, electronic survey a few years back, and what we found is about 2.2% of responders had a diagnosis of hidradenitis suppurativa, and another 1.7 to 1.8% had symptoms that were in keeping with hidradenitis suppurativa, although they were never given a definitive diagnosis. It's a disease that is characterized by painful, recurrent boils in the skin folds, so armpits and groin, also in other parts of the body. The reason for involvement of those areas because those are rich in a specific type of sweat glands known as the apocrine glands. And those apocrine glands are connected to the hair follicles in those areas. Pain and discharge and foul-smelling odor are the main manifestations of this and the symptoms that patients are suffering from. But it also has a significant physical and psychological impact on patients as well. While there's no cure that exists, and this is the same for all inflammatory or autoimmune diseases, there are some advances recently in terms of treatment that are helping with improving patient quality of life and controlling their symptoms and their ability to function. So the Scarred for Life report, this is an update that we did this year, and we compared it to the initial report, which we worked on back in 2017. So we're looking for the changes in the care for HS patients over a 3-year period. And it's a survey that it was circulated online. We had more than 500 responders to the survey. Of those, 37 were from Canada. And the majority of those, more than 95%, had a formal diagnosis of HS. And the majority were females. We know HS is a disease that's more common in females, but also there are other factors in terms of participants in patient support groups tend to be more represented, females tend to be more represented online and in social media in those support groups. And the survey was open for participation over a period of 6 weeks, and included individuals both who were formally diagnosed or those who had symptoms that were in keeping with the disease. So they were self-diagnosed, but they had manifestations that are in keeping with it, and included participants from both North Canada, US, and also international participants. I would like to thank AbbVie Canada for their financial contribution for the development of this report. So going through the patient journey, which starts with having the symptoms and trying to seek a diagnosis, and once a diagnosis is made, is trying to manage their disease and what are their major concerns. So in seeking a diagnosis, it is quite common for patients to be misdiagnosed. And the reason for that is there's lack of awareness among healthcare providers about this disease. And because it presents with those boils and abscesses, the most common thing that comes to the healthcare providers, whether family physicians or in the emergency department, that this is an infection. This is an abscess that need to be treated with short course of antibiotics. So things like boils, ingrown hair, skin infections are the most common misdiagnoses. And unfortunately, about 85% of patients had a misdiagnosis before the right diagnosis was made. In addition, we asked about the treatment that the patients received during that period before the diagnosis was made. And again, if you're suspecting that someone has an abscess or skin infection, the standard of care is to incise and drain. So cut it out, get the pus out, and that is the treatment of choice. And sometimes you would add to it a short course of antibiotics. Also, for patients, it does provide relief. So if you're in a lot of pain, when you open it up, that provide immediate relief, but without having ongoing maintenance therapy, you're just waiting for the next round or next flare. So it's important that we are proactive in our management of the disease. The second common treatment that patients are receiving is to inject with intralesional steroid injections. And again, those provide relief to patients. They are reasonable treatments when the disease is localized, so having 1 or 2 lesions that require symptomatic. But if you're dealing with more extensive disease, again, you need to treat this from the inside out to get the systemic inflammation under control. Again, along the line of seeking diagnosis, this is a very sad I would say, information that we found is that we're not, in Canada compared to the rest of the world, we're not doing a very good job in terms of the wait time to see a dermatologist or a surgeon. And this is very stark difference here, about 6 months to see a dermatologist compared to about 3 months internationally. And again, for surgeons, again, threefold, 150 days compared to 56 days to see a surgeon internationally. We're not that different from the so compared to back in 2017 and 2020, there's a slight improvement in seeing dermatologists. On the other hand, seeing a surgeon does not seem to have taken a bit longer. And although we don't fully understand why, my explanation for this is we don't have, the number of surgeons dealing with hidradenitis suppurativa did not increase. So we're recognizing more patients, they're seeing the dermatologist and being referred, but because we have a limited number of surgeons involved in hidradenitis suppurativa, the wait time to see those surgeons increased. There also, in addition to that wait time, is and we're going to come to it in our recommendations, is that even when the surgeon wants to treat the patient, take them to the OR, unfortunately, at the hospital level, we don't have enough OR time for HS patients. The priority goes to other conditions, including cancer, among another list of diseases. The other thing was along the line of waiting for surgery is comparing 2017 to 2020, and whether, again, we see that in 2020, it seems that patients are waiting a bit longer to have surgery done. And that goes with the fact that they're seeing the surgeon, but the surgeon, there are only limited number of surgeons, and they have a limited number of OR time to operate. It is unfortunate that we're still seeing surgery being delayed, waiting for making recommendations to quit smoking or to lose weight before the surgical intervention is introduced. And while there's some merit to that, because some of these can, especially smoking, can interfere with wound healing, there's certain techniques or doing the surgery in stages that would mitigate that risk. And then coming to diagnosis, and that's slightly good news in the sense that there seems to be improvement in the time to make a diagnosis. So we see that slightly more than 40% of patients now are getting diagnosed within 5 years of having their initial symptoms, and that was below 35% 3 years back. And again, we see that reflected in the 6 to 11 years. So that is a good news in terms of increasing awareness about the disease and being referred and getting the right diagnosis. In terms of management and who's involved in the management here, we see that there's slight drop in family doctors being involved in the care of patients. And while dermatologists, there's slight increase, but otherwise things seem to be more or less the same. I think this is a systemic disease with multiple manifestations and comorbidities, and I think it's very important that the family physician remains involved in the management of HS patients. And I'm going to expand on that going forward. Patients reported that on average, they have tried 15 treatments, surgeries, and lifestyle modifications. And whenever you see this number of treatments, we get concerned that if there's one effective treatment, you're not going to need 15 different interventions. Yes, we need to tackle this disease from different angles, but 15 seems to be like a large number of interventions, suggesting that none of them is a slam dunk in terms of achieving all the goals that we're trying to achieve with this disease. And of those who have tried these treatments, the things that they found most effective are surgical interventions other than incision and drainage. So having excision of inflamed area or having major surgery to an involved parts of the body. And again, this is a very effective, it is effective to that part to a degree, but we know without having a background medical therapy, it is a matter of time before it either returns at that spot or involves another part of the body. So, and the other part about this is we know by being on optimizing medical therapy that the outcome of the surgery is improved. So patients tend to heal faster, they're less likely to have complications. The area that the surgeon will need to operate on tend to be smaller. So it is really a combination of optimizing medical therapy and having appropriate surgical interventions. I'm not gonna spend a lot of time on radiotherapy because I think this information is not, doesn't really carry a lot of weight, because if you look at the data, only 3 patients had that. So one patient said it helped, and patient said probably made some improvement, little improvement, and one patient reported that it actually worsened their symptoms. And this is typically offered for cancer, so it's very limited, I would say, value in HS. CO2 lasers seem to have helped some patients, and CO2 laser, when it's used, it is used, it's very similar, it's considered a surgical intervention. You're basically destroying that area where the inflammation is happening and allowing the skin to heal with a secondary intention. Again, continuing on the line of treatment, it's important that we individualize HS treatment to the specific patient and specific patient needs. And we recognize that there are a combination of treatments are required. Of the non-drug treatment, significant improvement to most responders resulted from stress management, diet modification, and avoiding tight-fitting clothing. And all of those are important. We know that stress play a major role in flares, whether it's of HS or other autoimmune and inflammatory conditions. Diet modification, we still have a lot to learn about that. We know for sure that weight loss would tend to result in improvement in the disease severity. There's also some data about avoiding carbohydrates and sugars seem to help with reducing the frequency of flares. But there are a lot of unknowns in that area that we're hoping to learn more about in the future through research. And avoiding tight-fitting clothing seems to help through, because the friction itself, when a person is having a flare, that can be quite painful. So avoiding that minimize the pain until that episode is brought under control. Pain remains a major issue in patients with HS, and it's a very unique symptom compared to most skin diseases. Most skin diseases are either itchy or not associated with any symptoms, but HS stands out as a disease that primarily associated with pain. And what's concerning here is we see between 2017 and 2020 that it seems that the pain, there's increasing pain severity, or the way I would put it is, we're doing a worse job in terms of controlling the pain. And there are two possible explanations here. One is some of the interventions we've introduced are helping with the inflammation, with the discharge, with the odor, while so the pain is still standing out as one of the major issues. On the other hand, it could also point out that we're not doing, in terms of providing patients with pain management, we're not doing such a good job. And going back to the slide comparing who's involved in the care of the patients, and we see the drop in involvement of family doctors, I'm concerned that might be contributing to it, because dermatologists are not trained to prescribe pain medications. And we typically work with the family doctors, and when sometimes the family doctors would also include a pain specialist. So I'm concerned about that link being missed there, and that might be resulting in the differences we're seeing in the report this year. And it's important to the degree that only 11% of all responders consider their pain to be very well controlled. We're also doing a better job in capturing that. So for example, in assessing patients, I tend to ask few patient-reported outcomes, and one of the standard questions is about their worst pain in the last week from 0 to 10. And so when we're more aware about it and we ask about it, that might be also resulting in increased awareness about that issue. We also know if you're having those recurrent boils with discharge and pain, it is understandable to have a major and huge impact on daily activities. So if you're in pain and if you're worried about discharge, this could result in you missing work, not being able to perform as well. So this could inhibit your career progression. Could also impact your mental health, and that's very understandable. Some studies find that about 20% of patients with HS have a diagnosis of anxiety or depression, and some studies even higher than that. So it's very important for patients to adopt coping strategies with those. We also know about the impact on the social life, so inability to engage in social interactions, symptoms and side effects impact their ability to be active, and that becomes a vicious cycle. So patient is in pain, they're not able to exercise, they're not able to be active, then they gain weight, and then they gain weight, and then that can result in worsening of their disease. So it's our role as healthcare providers to try to get the disease under control so they are able to minimize, so this would minimize the impact on the quality of life so they continue to be active and perform their daily activities. Clothing options are restricted, and impact on mental health and personal relationships is understandably affected by this. It also affects their relation with their family, including their parenting, family finances, many of the things, including dressing change or over-the-counter treatments, all of those, and if the patient does not have drug coverage, all of those would have significant impact on finances. And that would have also impact on mental and emotional health of the whole family. There would be worry, loss of hope, and embarrassment. Impact on intimacy, more than 50% of patients with HS reported that in some studies. They are scarred by previous partner reaction, fear and anxiety about being intimate. Friction can lead to pain or to flare, and weight gain from inability to exercise decreases confidence and self-esteem. We also asked the patients about their interactions with the healthcare providers after the diagnosis, and what are the things that their healthcare provider was able to discuss with them. And there's some good news here in the sense that it seems that the healthcare providers are spending more time or able to discuss with the patients about HS, about the treatment options, about the cause of the disease, and what to expect with it, and how HS affects the risk of getting other conditions. So what are we, in medicine, we call these comorbidities. So we talked about patients with HS being more likely to have depression and anxiety. We also know that they are at high risk of having cardiovascular disease, diabetes, hypertension, high cholesterol. They're more likely to have inflammatory arthritis, inflammatory bowel disease, among others. And still, there's room for improvement. 45% of patients were not satisfied with their healthcare provider knowledge about the disease. And then we asked the patients about their needs related to HS, and 99% revealed that they are struggling with at least one aspect related to HS. And the number one issue was managing their symptoms. And then the second issue was the lack of awareness among healthcare practitioners. And the third was depression, and followed by managing daily activities and the lack of societal awareness of HS. And that's where things like HS Awareness Week, we're hoping would address some of those issues. Also, we asked to provide advice to people newly diagnosed with HS, and these are messages of hope that patients, to the most part, we're sharing. So remember, you are not alone. Keep stress as low as possible. Join an online support group. Talk to your family and friends about it. Try not to hide it. It's not your fault. It's not something you've done, so you should not be ashamed or afraid to talk about it. And you should not be trying to hide it. Search for credible content like the Canadian Skin Patient Alliance. Familiarize yourself with the disease. It's often associated with HS, and I think this is one of the most important things for patients, because recognizing those early and the risk factors and trying to reverse that is also important. Get started on treatments as soon as possible to prevent complications, so the permanent scarring and the impact on daily activities and work and intimacy. Keep a diary and take pictures to track your progress and help you identify triggers. Seeking support is essential to being your best advocate. practice regular self-care to optimize. Remember, you come first and your health comes first, and you should not be ashamed about that. Some of the recommendations we made that the report, based on the information we got from the patients, number one is to raise awareness about HS to support quicker and more accurate diagnosis. So increasing awareness among healthcare providers, especially those who would be, it's likely for a patient who presents with symptoms of the disease to present to. So whether it's the emergency room physicians or the family doctors, by far those are the most likely to encounter the patient first at the beginning. And then the second was relating to ensuring patient access to diagnostic tools and collaborative care. This is a systemic disease and require collaborative care. So we talked about the dermatologist, we talked about the surgeon, the family doctor, and depending on what are the other issues that are at hand, other specialists will come into the circle of care as well. Regarding treatments, support patient access to safe, effective, and affordable treatments to manage HS symptoms and to manage the disease. And those cover both access to, prescription medications, whether the biologics or traditional therapies, and also addresses issues with non-prescription medications and needs. So wound care supplies, supplements and vitamins, and for example, zinc supplement, which is over the counter. So those are the things where we think some of the private insurance plans should extend into those areas. Also, as part of that is having access to surgical care as appropriate. And so one of the issues would be, we talked about surgeons who are willing to operate on HS, but the hospital administration is not giving them time to operate on HS patients. So those were some of the needs that need to be addressed as well. Care, including strategies to manage the impact of HS on daily life in comprehensive care plans. So evaluate every patient with HS for depression, and offer support, care, and referral to specialists where appropriate, and integrate a pain management discussion into every interaction with patient with HS. And this so can be taken at different angles. So there's a role for dermatologists to recognize that, and for a family doctor to be involved in the management, and if appropriate to, if needed, to refer to a pain specialist as well. Supporting patients, so support the needs of people living with HS, enhance availability and access to patient resources that provide information on treatment options and support groups for newly diagnosed patients. And this is one of the efforts toward that, and organizations such as the Canadian Patient Alliance are playing a major role there. I want to finish with a timely issue, which is the COVID-19 pandemic and the impact of that on HS patients. So with the pandemic, there are some concerns. One of them, the first concerns was actually lack of access to dermatologists, because like all the resources of the healthcare system were basically declared a state of emergency, and all the resources being shifted toward managing the pandemic or preparing for anticipated surge in cases. So many dermatology offices closed. At the same time, we try to provide virtual care for many of our patients. But then came the concern about how do patients with HS fare during the pandemic if they develop COVID-19, whether it's related to their disease itself and their comorbidities. So we know some of the comorbidities that were reported to be associated with a worse outcome if someone develops COVID. So obesity, for example, hypertension, diabetes, and those are more common in HS patients compared to the general population. We also know that patients with HS are receiving medications that are working through modulating the immune system, and whether that can result in worsening, increasing the risk of getting infected, or how would they fare if they develop the infection. And we're still early on in the registry, but we so far have about we have more than 30 patients who are enrolled. And so far, I would say, I would warn about drawing any conclusions because these are just raw data, but so far so good that everybody survived. Luckily, we haven't had any mortality in the patients who developed HS, who have HS and developed COVID. And most of them actually did very well. They had very mild disease. Only a small number who required hospital admission or being admitted to the ICU. But we need to capture more data. And one way of doing that is, so because we know that patients are not having access to their dermatologist or healthcare provider, the registry itself actually allows for the patients, if they've been diagnosed with COVID-19, they can enter their own data. And the registry is not collecting any personal identifiable information. So there's no concern in terms of privacy. So I would encourage everyone, hopefully nobody been affected, but if anybody been affected, then to share their information, which hopefully would help in making decisions about providing care to patients going forward, because this pandemic is going to be with us for a while. And we need some guidance in terms of how to best manage patients and to give them advice on how to manage their disease. With that, I would like to thank you all for joining us today. And I want to thank the Canadian Skin Patient Alliance for this terrific work on this report.
Great, thank you, Dr. Alhusayen. We do actually have a couple of questions for you, if you're ready.
I'm ready.
The first one was regarding the survey. And the question is, did the survey capture the direction of patient referrals? So for example, did the dermatologist send the patient to the surgeon or vice versa?
Right, so I don't think the survey captured that, not to my knowledge, and Rachel can correct me, but I don't think we captured that part. It was about who's involved in your care and how long does it take to see those specific specialists. But Rachel can add to that.
That's correct, Dr. Alhusayen. We didn't track the directionality of that. We were just looking at the number of the number of visits and things like that.
And another question that we received was regarding the available treatments for HS. Since some of the treatments that are available cannot necessarily be taken by all patients, for example, those that are thinking of becoming pregnant or might be pregnant, are there other treatments that are been shown to be effective and that could help?
Right, so, and that's where it's very important to individualize the care to the specific patient and their needs. So we take into account things related to their comorbidities, to their plans for life going forward, and their previous treatments and their experiences with those treatments and their history of allergic reactions as well. We know that there is one medication that is approved by Health Canada and by the FDA, and that's adalimumab. But at the same time, we also use like a huge arsenal of treatments, including some natural therapies and supplements, some traditional therapies, whether we're using antibiotics for their anti-inflammatory properties. And I'm feeling that the question was about someone who's planning to get pregnant. So some of those antibiotics can be safely used in pregnancy. Some of the supplements can be used safely in pregnancy. Many of the biologics are also, with proper counseling, can be used safely in pregnancy. So it is really a discussion that, if you're planning to do so, have that discussion early on with your specialist, with your dermatologist. They can certainly work you through the options and come up with a plan that's going to meet your needs and ensure that this is done in a safe way.
Okay, great. Thank you. So another question was, can you tell us a bit more about the role of antibiotics in treating HS? Seeing them used so much has come as a bit of a surprise.
Sorry, what was the part about the surprise?
Just recognizing that the use of antibiotics in treating HS.
Right. So actually, antibiotics have been used for a very long time in treating HS. And the main reason that antibiotics are being used to treat hidradenitis suppurativa is many of those antibiotics have anti-inflammatory properties. So it's not because we're targeting an infection. So antibiotics like the tetracycline class of antibiotics, the doxycycline, tetracycline, we also use them to treat acne, which again, to help with the inflammation of the hair follicles. So those are the tetracyclines, and then we also use a combination of two antibiotics called rifampin and clindamycin. There's good evidence to support their use. That we typically use them for a course of treatment, which is typically about 3 months or so. They're concerned about using antibiotics long-term because of the concern about antibiotic resistance, and those antibiotics, many of them would require regular monitoring. So the goal typically is to go through a course of treatment for about 3 months and then plan for a more permanent or long-term treatment. We do see in a small subset of patients, they might need other course of antibiotics as we go forward, because we are not achieving the full control using immune modulation. So that's, there are also some antibiotics there's some role. The other reason that sometimes we use antibiotics is that in those deep sinus tracts, we have overgrowth of the biofilm or the person's own bacteria, and sometimes and that can drive more inflammation. So by using certain antibiotics, that help with killing some of that bacteria and calming down the inflammation.
Great, thank you. So we have a couple more questions. I'll just put it out to the attendees that if they do have a question, to put it either in the chat or the Q&A function. But another question we have is, what do you see as the top three questions in HS that need to be answered through research?
Only 3. Okay. I think so. One of the important things for us, I think, is the role for combination treatment in managing hidradenitis suppurativa. So as we've seen through the survey, on average, patients have tried 15 different interventions. So we need to know, and with a single intervention, there's about 40 to 60% of patients will achieve the outcome desired. So we know that in real life, we're using combination therapy. So we would like to know more about what are the most effective and safe combinations to use and when to use them in specific patients. The second part that I would we need more information is managing HS in special patient populations. So whether in the pediatric age group or in pregnancy or in specific comorbidities. So if you're dealing with, we have cancer patients who have HS, and so what are the treatment choices in that case? We have patients who are taking blood thinners or blood clots, other inflammatory conditions. So what are the treatments of choice in that case? The third area where we need, I would say, about the role of diet and supplements in HS. It's an important area, and we don't have a lot of data in that part. I can keep going if you want, but I was asked about 3.
Okay, great, thank you. Another question we had received actually was about the effects of aging on HS. So for example, some conditions, as you age, you tend to outgrow them, or as you age, they get worse. Do we know much about the impacts of aging on HS?
Right, so initially we thought that because it's a disease that has an onset on the 2nd or 3rd decade of life, we think, and we still think it plays a role, that hormones play a role in the pathogenesis of HS. And then some of the observations that were made was we actually don't see a lot of women post-menopause with the disease. So maybe post-menopause, because they don't have the hormones have changed, and that's why they don't have severe disease. That being said, I think with the increased awareness of the disease, we do have, although it's not as many patients, we do have patients in their 60s and 70s with hidradenitis suppurativa. And it is quite possible that there are multiple factors contributing to the disease. While hormones might play a role, a major role in some patients, they might play a minor role in others.
Great, thank you. So I think what looks to be our last question is, what surprised you the most when you read the report?
I think the part that I would say two things surprised me. Things that I'm really concerned about and upset about is the wait time to see a physician, a specialist in Canada compared to the rest of the world, and that is concerning, and we need to do a better job in that. On the other hand, some good news, I would say that we already seeing improvement in terms of shortening the time to get a diagnosis.
Right.
And that's an important part. So getting the disease, identifying the disease early and starting interventions.
Okay, great. So that looks like that's all the questions that we have. So Rachel, I'll pass it back to you.
Thanks, Helen. And thank you, Dr. Alhusayen, for sharing all of your insights with us today as we walk through some of the findings from the report. This is also a really great moment for us to thank you for your dedication to the HS community. You're very well respected, very well regarded, and we feel very fortunate that you were available and interested to help us shape the survey and develop the report and its recommendations this year. So thank you again for that.
Thanks, Rachel. It's my pleasure, actually.
And I wanted to let everybody know that more information about the report can be found on CSPA's website, including some of the advocacy and other initiatives that we've already undertaken in order to advance these recommendations. And you'll also find there, probably early next week, the recording of today's presentation. So without further ado, I want to thank everyone for joining us again on this lovely Friday evening, and wish you all a good evening.